Okay, so these are my disclosures. I think we all have a different disclosure slide. Main disclosure is that uh, the CDC funding that specifically to the topic that we're talking about, um, no commercial conflicts. So I had a bunch of goals on the slide, and I kind of actually erased this at the last minute because I do think, as I said, this is a rapidly changing environment, and I think the goals for today should be this is a blank slate. And we are, uh, my goal for our discussion is to save our work, and that I think is why we're here to share what we do and why we think it's important, but also to elicit your ideas uh, and perspectives. So going back a little bit to thinking about injury science, the intersection between injury science and emergency medicine is rich. And it is also one that may not be entirely recognized, I think, on all sides of the equation here. If you put injury science on one side, emergency medicine or emergency care delivery, emergency prevention on the other side. Please, Steve and others, if this history is incorrect, please let me know. I think it's basically really an abbreviated story, which is that, as many of you know, injuries were not viewed as science really until the mid-century, 1940s, 1950s, when people began to think about injury as a disease that could be explored and studied, modeled, not unlike infectious diseases, etc. A series of legislation at the federal level, followed by a series of white papers from influential organizations like the National Academies of Science and the National Research Council, highlighted the impact of death and disability on society, which led to an investment at the federal level as well as at local levels in thinking about science and building a coordinating infrastructure to study this. Fast forward to the mid 80s when the CDC finally, through a variety of legislative efforts, gets about $10 million a year to build a network of injury control research centers across the country, and also to invest on its own intramurally in injury writ large. The goals of the injury control research centers are to, at a very high level, put research into action to prevent injuries and violence. Currently, there are 11 ICRCs across the country, each embedded in a university. They all have three-part mission, which is research, outreach, and training. And the topics that we focus on, again, are a little bit broader than this, but are particularly emphasized through our CDC mandate, which is interpersonal violence, opioid overdose, older adult falls, transportation safety, traumatic brain injury, suicide, and actually more. With that, I can pivot a little bit to talking about the Penn Injury Science Center, known as PISC, and then we'll keep going. But I'm going to stop and see if you guys have any questions at this stage right now. Okay. So Penn Injury Science Center, our motto, stop it, fix it, live on, is a place that's near and dear to my heart, and also Doug, who is going to be sharing stuff about Michigan, was really one of our founders here at Penn. So it's really a pleasure to be talking to you guys about this. Our history, maybe not unlike the history of injury science in general, has been an upward trajectory, one that started specifically focusing on firearm injury, going back to the 90s, and then a violence collaborative that evolved into the PISC, which is the Penn Injury Science Center, that was funded as what we call a mini or a baby ICRC in 2015. developed was actually technically a developmental ICRC, focusing on environmental determinants of injury and violence. And then that evolved into a comprehensive ICRC through a 5-year CDC-funded grant, focusing on risk and protective factors across space and time. That was led by Doug Weed. And then in 2024, we were refunded for another 5 years as a comprehensive ICRC, focusing on injuries across the lifespan, being equity-centered, and particularly action-oriented. Not unlike other ICRCs, we are divided into 3 different cores, a research core, an outreach core, and a training core. They really are somewhat self-explanatory, but we think that we're able to take unique perspectives compared to other centers in terms of how we do our mission. This is our org chart. What I really want to focus on is our research projects to maybe demonstrate to you that what we do is not, that is really multidisciplinary, that is focused on many broad but really super important and understudied areas. This figure represents the lifespan. So if you think about being across the lifespan with childhood on the left and senior adults on the right, and then also violence and injury that has both equity and action-oriented science with translation stages as well as implementation stages. So in our first study that is embedded into our ICRC, it's a 2-year study that is led by 2 researchers from Children's Hospital, Pennsylvania, and it's actually focused on bullying, which is, you might not think of as an injury, but it is an ACE, which is an adverse childhood experience, and that is defined by the CDC as serious and important causes of injury. So they are running an RCT in the Philadelphia schools focusing on 3rd graders, and they're training the trainers basically on an evidence-based implementation study focusing on ways to actually help teachers prevent bullying in the schools, which can have many long sort of downstream and proven consequences. Really exciting study, important. They're about to go into the schools this fall. They've already ramped up. They've already built these relationships with schools. The idea that this funding potentially could go away, I think, would be a huge disruption. So sort of just putting a pin in that one. The second study is one that is focused on teenagers and adult peer leaders who get trained in problem-solving therapy to prevent the downstream and intergenerational impacts of ACEs, led by Carmen Alvarez at our School of Nursing, and is focused on preventing basically the downstream impact of adverse childhood experiences in young adults. The third study is one that will start in our middle of our cycle and is focused on looking at social media as a marker of violence and violence prevention, led by Eleanor Kaufman, a trauma surgeon at our shop, and Desmond Patton, who's a communications researcher. And they're really using AI to actually be able to identify in social media posts what is language that actually leads to violence, as opposed to language that is just about, regular things that teens do, which, can include beefs, but don't necessarily lead to violence. So being able to sort aggressive language that is going to lead to violence versus aggressive language that is actually just, teens being teens. Really exciting and interesting with a whole intervention component once they basically figure out what that language is. And then the last study is one focused on older adults. Opioid use disorder is not usually thought of as an older adult problem, but it is, particularly in Philadelphia. And it's a study that's going to be focused on actually preventing overdose using harm reduction strategies and comparing them in a variety of implementation methods in supportive housing for older adults in Philadelphia, the new Portland House. So, reducing injuries across the lifespan, being equity-centered and action-oriented. Really important studies that, again, I think are all under threat, and we're hoping that we get a chance to complete these. I'm going to sort of fast forward and tell you a little bit about our outreach activities. We do a ton of work related to matchmaking folks in our community who are working at the edge of injury prevention and violence prevention, and our research team. We do this through a variety of mechanisms. We provide technical assistance to folks who are looking at the policy as well as the community level to actually conduct research and to be able to sort and understand data. And then we have a whole focus on dissemination, which is including a catalog that helps researchers tailor their work to specific audiences. On the training side, we do some standard stuff like postdoc training and fellowships, but we also have a national training learning lab that is run out of Penn that is focused on actually helping folks who are working in injury science, even outside of ICRC. So if you guys are interested in conducting or being engaged in injury science sort of collaborative, this is a lab that helps do that. So that's Penn and Penn Injury Science Center. That's injury science writ large. I'm gonna hand it over to my colleague Jonathan Rupp to talk to us about Emory, and then we'll go to Doug, and then we'll break and talk about injury science. Awesome. So that would be the rundown. Thanks.
Thanks, Zach. Okay, just want to make sure everybody can hear me. Y'all are okay? Excellent, thank you. So Zach covered a lot about the ICRCs program, so that saves me from having to actually do that. Before I get started, nothing to disclose, and we mostly want you to learn about our ICRC and the ICRCs program. Obviously, as Zach said, in the hopes that you all can help advocate for continued support for injury science, but also in the hope that you all can support the development of injury science programs at your institutions and understand how to participate in some of the stuff that we're doing that really engages on a national level. So just to give you a history of our center, it actually in many ways looks a lot like Zach. It started out with a heavy focus on firearm injury prevention as well as IPV prevention. Founded by Art Kellerman and Ricardo Martinez in 1993. We went through a history of having CDC, ICRC funding first in 2009, and then again in 2019 and again in 2024. So we've been in the ICRC program for some time, obviously multiple iterations, multiple different faculty leaders. And if you look, we've actually had pretty consistent leadership over the years. Art Kellerman, Deb Howry, David Wright, who's in the room, and then myself for the past 8 years. If you look at who we are, right, there's approximately 100 core faculty. We span Emory and 6 other universities in Georgia. 18 of our core faculty are from emergency medicine. We're obviously headquartered in the emergency medicine department. And we very much want to support and uplift emergency medicine faculty and increase their scholarly output and engagement in injury science. Our center is a little unique in that we support outreach through 5 volunteer task forces that address the top 5 causes of injury death in Georgia. So overdose, falls, TBI, motor vehicle injury, and violence. If you look at our structure, this is just some of the folks that are involved. We have, and you can see in red squares, those who are from emergency medicine that are part of our leadership. Joe Carpenter is in the room, who leads our drug safety task force. Cheryl Heron was here earlier, who is part of our education core as well. One thing that I will point out is that we've been really intentional on including in our leadership people who represent the different schools and colleges of Emory to make sure that we have institutional buy-in. I'll also point out that we've been intentional in having shared leadership with the Georgia Department of Public Health so that we can collaborate and support the work that they're doing in terms of applied injury science. Georgia Department of Public Health staff co-lead some of our task forces. Our outreach core director is also the director of injury prevention in the Georgia Department of Public Health. So obviously we have a lot of research partnerships with them and leverage their connectivity and their ability to apply for funds that we are not eligible to apply for. As Zach said, injury centers have research, outreach, and training functions. Our outreach core handles social media. We do quite a few webinars. We do publication briefs trying to feature and uplift the work of our faculty. We host meetings and symposia. We do an annual violence prevention symposium. And we've started to do training for peer educators as well. We're working in overdose prevention under Joe's leadership. And then, of course, we work quite a bit with national networks. In terms of training supports, we do focus a lot on developing extramurally funded research at Emory, and so a lot of that is supporting the development of junior faculty and their ability to write proposals in the space and engage. We support a certificate program and other work aimed at developing the next generation of injury and violence and overdose prevention professionals. So this is housed in our School of Public Health, but engages across the university. So we even have folks from our School of Theology that participate in the certificate program. So it really is quite diverse from a set of backgrounds. We support sets of internship programs and pipeline programs. We have an Annie Casey funded internship program where we support youth who are underrepresented in both injury science and medicine and help them partner with community groups working on community violence prevention. We do quite a bit in terms of training. Zach and the Penn Injury Science Center have a very similar model to this. But what we do is try to support community groups, particularly recognizing that it's small community groups that are doing a lot of the boots on the ground work in injury and violence prevention, and they need organizational supports to be effective. We have structured a lot of our education and training around providing those supports and have a series of learning opportunities aligned with their career development. We also partner with them actively on grants, grant proposals, and unfunded research. So I talked a little bit about engaging community partners. We got multiple ways to do that. I mentioned trainings. Our task forces engage the community partners that are more developed and can participate in those structurally that have the time and are looking to collaborate across disciplines, not just within sort of their own niche. We do quite a bit of participatory research training aligned with our focus on engaging communities. We feel that this is really important. We host meetings and symposia and then provide direct technical assistance to community groups and other partners. So I wanted to talk a bit about sort of the spectrum of research projects that we've supported. I'm not going to go through all of these. The slides are available, but I do kind of want to highlight thematically the things that we've funded over the last 5 to 6 years. So certainly work in community violence prevention. The first one there, I think is something that's been particularly important for us, trying to look at how we can support effective implementation and uptake of the Cardiff model for violence prevention. Cardiff is a demonstrated effective intervention for decreasing violence in communities that focuses on data sharing partnerships between hospitals, law enforcement, and communities. There's a national network for that Dan Wu from our center, Steve from the Medical College of Wisconsin, and other MCW staff, as well as folks from Penn, helped contribute to. I also think I want to highlight, let's see, a couple of these. Other work on IPV prevention, quite a bit on suicide prevention, quite a bit on overdose prevention. We funded a project associated with barriers and facilitators to community drug checking. So how do we more effectively get fentanyl test strips, xylazine test strips, and other testing for other contaminants in the street drug supply? How do we effectively increase the uptake of that among people who use drugs and their social networks, which is something that I think is really particularly important. And then I think I'll highlight the last one as well. So there was anecdotal evidence at the time that we funded this project that pediatrician counseling of parents helped decrease the intergenerational transfer of adverse childhood experiences. So parents' adverse childhood experiences affect their parenting style, which affects their child's potential to be exposed to adverse childhood experiences, both from that parent and otherwise. And so the question was, can pediatrician counseling modify that? And so the answer is sort of yes. We learned some things that were important to do and some things that mattered and did not matter. So lots of things that are important to public health and dream violence prevention. We provide a lot of other supports to our members, our faculty, and our community partners. We do a work in progress series that's really focused on helping faculty develop effective proposals. We organize peer review of those proposals, both internal and external to Emory. We help build teams to apply for extramural funding and intramural funding. And our center has supported quite a few special issue journal articles, just to try to make sure that our work's out there in a way that's easy to access and in a single place. So I will stop there and I think pass it off to Doug.
Thank you, Jonathan. Thank you. Thanks everyone for being here. Thank you, Zach, for organizing this. Does your name tag say President-elect?
The SCM Foundation, everyone, we're in challenge mode, please give.
Okay.
Yeah.
That could be part of your introduction.
Yeah.
Yeah, that wasn't planned or
Yeah.
Doug Weeb at University of Michigan. And part of my story is that my primary appointment is in emergency medicine. I also have a secondary appointment, a wet appointment, as we say at Michigan, which means I do get paid there. It's not token. Secondary appointment in the School of Public Health in the Department of Epidemiology. And even strategically moving there after 20 years at Penn, which I very much enjoyed, I've been hoping to be able to create bridges from emergency medicine to public health and other groups on campus at a place where there has been so much growth, as I will try to describe to you. This is a landscape of the 11 CDC-funded ICRCs. I pop it up just briefly to point out that the University of Michigan is on the Great Lakes, as are 4 ICRCs. Medical College, we count that as Penn Injury Science Center on a lake.
Far.
On a lake.
Yeah, on a lake.
And also Columbia
Schuylkill.
in
Yeah.
Manhattan is on a lake. As we look for themes in which to define areas in which we might find a concerted effort. And of course, the CDC and all of us have been hoping to have better representation geographically across the entire country. So here's the timeline at University of Michigan. And I see, so it was 40 years ago when the first ICRCs at the CDC were funded. It was 10 years after that, Jonathan, your colleague and mentor, Ron Mayo, started an injury center at Michigan, not CDC funded. Dr. Rebecca Cunningham, emergency medicine, now the president at University of Minnesota, started an emergency medicine-based ICRC, and they consolidated together, brought the campus together in 2010. It was here when the University of Michigan received their first CDC grant. There was a short little time in between, and that's when Penn was first funded. The ICRCs were on multiple cycles, and it was here that the CDC corrected, and now all the ICRCs started at the same time. Patrick Carter was a director at this at the University of Michigan. I believe one of the mentees of Jonathan, while Jonathan was at University of Michigan. But very quickly, Patrick and colleagues were successful in getting a firearm injury prevention center institute funded. So that's at the university level. Dr. Carter co-directs the Firearm Institute, and I moved there in 2002 to direct this injury prevention center. And like the other ICRCs that you've heard from, we touch on a range of injury prevention topics and also do have some priority topics. But we're really working in a landscape at University of Michigan that historically has had a lot of growth in the injury science space. And it's very important for us to try to appreciate that as we think about how do we continue to foster further growth and also create efficiencies, even more so now in the new administration when there's a crisis going on in how we all stay solvent. The Institute for Firearm Injury Prevention is on here. There's also an Opioid Research Institute, again, university level, started with $10 million from internal funding. There's also a concussion center, started with $5 million. And so those are examples of how injury science has very much grown at the University of Michigan. External partners too, there are many across the state of Michigan, the Great Lakes area, and also across the country. Here's how our org chart is structured. It has the same large bins as the other centers. And also we have an internal advisory committee, an external advisory committee. And one way that we are set up is to have content experts, faculty members, clinicians, and researchers across many different injury topic areas. I put up the folks briefly so you can see who are in the cores: the admin core, the outreach core, the training and education core, and also put up these very important folks who are the staff working at our center. At this center, one of our defining features is we have a lot of real estate. We're very fortunate that EM has given us, it's about 40,000 contiguous square feet, really nice windows, and we have a lot of staff working all together in the same space, which is really quite amazing. And then here are the content expert leads. In the past year at ICRC, we benchmarked, we all recently completed an annual report to the CDC to report back on some of the education, outreach, research accomplishments that we've had. At the admin core, these will be quite consistent, I think, with what the other centers have. We provide administration, scientific, and fiscal management. We continue to leverage the center's partnerships with academia. We connect researchers and community partners and policymakers, and we actively collaborate with other centers across the country. Our core projects, all these projects are funded and have 4 research projects. We focus on surveillance overdose for the state of Michigan, promoting community conversations to end suicide, evaluation of school-based social media material needs identification to prevent youth violence, and also a study to improve the delivery of care through athletic trainers in collegiate sport concussion prevention. One of the projects that we administer out of this center is the Ivy League Big Ten Epidemiology of Concussion study. I'm the PI of that, and I've been PI for a number of years, and now we've set that up, thank you, Zach, as a partnership actually between Michigan and the Penn Injury Science Center. Here's a new one for us, and this was a charge when I started at the center. Dr. Newmar at the time was the chair, said, can we help support faculty, especially those who are not primarily researchers, but still have to have academic scholarship? Can we help them with what they need to do to get out papers and to be presenting here? And in the spirit of trying to create collaborations across campus, we engaged biostat students in the School of Public Health, Department of Biostatistics, overseen by, we're so lucky to have Dr. Jim Cranford, research professor in emergency medicine, who now, instead of working alone to collaborate, has literally built a team that's been highly productive. In the past year, we've had really good productivity, and Celine and Roar are just amazing. They're off to PhD programs now, but this is supported by the current chair, Prashant Majan, of emergency medicine. So that's been something that we've stood up, and it's been very successful, and with the blessing of the chair of Biostat in public health. In me moving there and seeing all of this growth, I'm very interested in how researcher lineages can keep being built as we try to grow the field and think strategically about that. We also have funding from the CTSA on campus at the University of Michigan to see if mentors can produce mentees who produce mentees, and we're trying to figure out structural facilitators of that and structural barriers for that. So that's a fun little project that we have going on. The Outreach and Translation Core develops new and extending new and existing connections. We foster the transfer of injury prevention science knowledge. We provide consultation and technical assistance, and provide training programs, still diversity, equity, and inclusion training for researchers, public health practitioners, and others. One of the projects in this core that's been very successful is running a very near real-time overdose surveillance system run by Jason Goldstick, where for all counties but 2 in Michigan, the coroners report within about 48 hours deaths from overdose. And Jason has got that popping up on a dashboard so that locally individuals can know if there are emerging hotspots and try to react locally much more quickly. In collaboration with Medical College of Wisconsin now, we're working with them to help translate what we've done there and reciprocally learn about some of the good work that's been done in Milwaukee and try to do that in Michigan. We promote evidence-based interventions. There's one for graduated teen driving with agreements between kids and their parents, and a safer prescribing toolkit. Really do a lot of outreach and dissemination. And then in our training and education core, we have educational events. We have an injury certificate also, Jonathan. Internship, student opportunities. We foster postdocs and junior faculty. And we also have a number of massive online courses. A bit more information on these is here. In the old days, very recently, summer interns were invited to come and spend time at the CDC in person, which was an amazing experience for fellows. CDC has unfortunately had to end that opportunity. And so that's an overview of what we're doing at the Injury Prevention Center at University of Michigan. Here are some action shots of all the folks, and I look forward to discussing with everyone.
All right. Thanks, Doug. So we're gonna like pivot to sort of a discussion. We have about 15 minutes, so I'm gonna moderate, but I really want to also make sure to leave time for questions. Do you guys want to sit? How should we sit, or should we just stand? Okay, we're gonna stand. Standing desk era, right? So we can do that. Okay. One of the things that that I think makes our centers potentially unique in terms of how research centers work across the country in other domains is collaboration. Our centers are both unique and also different in other ways. And I wanted to get your sense on how you think both our centers both differ and in terms of how where they overlap and how they can complement each other. And Doug, you've directed 2 injury science centers funded through the same mechanism at 2 universities that have a lot of similar mission overlap, but do very different things in some ways. So maybe I'll start with you and sort of we can talk a little bit about that. And then again, I want to frame this discussion around how we can advocate and emphasize what we do is important because for all the reasons. Yeah.
Thanks, Zach. One place I'll start on that thought is everything is relative. How do these centers differ? Everything is relative. We won't know it's relative until we've had at least one experience and another experience. And part of my motivation to move to University of Michigan was to just enjoy a new phase of my career in a different landscape. And Zach, I was immediately impressed upon it. It was immediately landed on me that the way we talk about Penn is that it's on one contiguous piece of land. All 12 schools are there, and it is literally easy to get to people's offices and collaborate. And when I was there, I found that to really foster a collaborative environment, and people even talk that way. At the University of Michigan, the way they brag about their campus is that it's a disaggregated campus. There's a main campus, but there's real estate all over the place. More is better. On one hand, that's good, but there are literally physical barriers. So it's not easy to see everyone in person. Also, briefly, I was focusing on how much growth there has been. The injury center that my predecessors ran, they described, did spin off the Concussion Center, Opioid Overdose, Firearm Institute, but they now very much have been successful and are running in silos. I think investigators have been incentivized to build them upward, and maybe that's worked okay because resources have been good, but there's not efficiency between them. And so in that landscape, I think things are separated, and especially now, as there's a bit of a crisis, I think we're starting to think more about how this could have been built with continuity and growth, sharing resources. So that's an opportunity that hasn't yet been taken advantage of in response to a challenge that I see there that I didn't see at Penn.
Right, yeah. I don't know if you have thoughts on that, or specifically in terms of how we, maybe I'll ask a different question for you, which is, I think there's probably a lot of folks in emergency medicine who do work that fits into one of these injury buckets, or who aspire to do that kind of work and don't have this sort of dedicated, extramurally funded injury research center infrastructure that exists. And yet this network, in theory, exists to support and build up injury science across the nation and beyond. I don't know if you have specific advice. If somebody comes maybe from even outside of your center and is interested in either collaborating or doing work, how can we and how do you address that?
Yeah. So there's a couple of different ways. So particularly in our center, we have a heavy focus on engaging faculty across the state, because there are partnerships that we can facilitate through the Department of Public Health, through extramurally funded research that involve those faculty.
Mm-hmm.
And so typically the way that we engage extramurally, we start by encouraging faculty to participate in one of our task forces. Now that serves several purposes. So a lot of times if somebody's coming to you from outside saying, how can I get involved? What they're really asking for is, how can I find partners and expand my network? And that's one of the reasons that we created those task forces. So we have faculty come in, participate, get to know the leaders of the task forces, get to know the members, and expand their networks from that. Once a faculty member from outside of Emory starts to engage, just so you all know, we're about 1/3 outside of Emory, 2/3 within Emory in terms of core faculty. And so once those members start to engage, we then can bring them in when there's an opportunity to plan for a research project, or to do education and training, or to feature some of their work. We actually go out of our way to try to feature those who are outside of Emory, because we want to make sure that they are engaged in what's going on in our center.
Great. I'd like to engage this audience now, and I know normally we open up for questions, but maybe to flip the script a little bit, because we do have two former injury center directors in the audience. And I think the big question, as when we let off, is how do we move this enterprise forward? How do we prepare for the looming storm related to funding threats, related to CDC, and all it's going through? What you guys were working in injury science back when it wasn't as well funded, and we have to be able to keep going. So I don't know. I'll just open it up, but maybe Steve, you have some insights to start.
Thanks, Zach. I think that the landscape is changing, and I think one of the things that is an opportunity for this, the symbol for Chinese crisis is danger and opportunity. And so the opportunities, I think, are with health systems. There's now the Network for Prevention of Gun Violence. They have supported gun research. Kaiser Permanente is supporting firearm-related research on suicide. So I think health systems are a place to look. Level 1 trauma centers are dedicated to do injury research. And I think that's a natural partner, and I think a natural partner to build in ways that are fundamentally a way to build up injury science on campus, while the national target of getting an injury center is in a tenuous position, as you've been outlining, and I don't know where that's going to go. So I think the health systems are a natural place to look for partnerships, particularly children's hospitals. There are 125 pediatric trauma centers. So I think those are another place to partner. And we're well placed as emergency physicians to inform what's failing in our community. And I think the Cardiff model is an example, an excellent example of the way an emergency department can get engaged in the community with police, our natural partners, in addressing assaults and violence. So, a couple of thoughts in this chaotic environment that we're living through for the near future. And we haven't even talked about NIH, who wants to steer clear of gun violence because it's too political. So there's a lot of moving parts here that we should, huddle more and more to figure out where we want to go with this very interesting landscape. So stop there. Good news and
Yeah.
dangerous news.
Dr. Ryan, I'll listen to other thoughts on this.
Jeff and I have had these conversations over and over again, trying to develop a strategy. I think it's always a diversified portfolio is the way you survive, period. Never put all of your eggs in one basket, of course. And depending on CDC funding, we always consider that a privilege. And so it's really in the diversity and the strength of the faculty that you engage in your center that provide sort of that research, fundamental research grants that we've always sort of survived on. Of course, now we don't know what the NIH is going to be doing, but with a lot other than gun violence, most of the other topics are still palatable and good topics. And the survival of our initiatives are going to be on individualized grants, collaborative grants that we go out and get that have a component structured around the injury prevention model. That's the hard way, because it's one at a time, and it doesn't allow you to sort of really go out and do the things that the center has allowed us to do, explore areas that we weren't so confident in. Cardiff model, you're right, it's something that we're doing at Emory. It's just a beautiful model, certainly for injury. I don't know if it could be applied to other areas, other than violence, but it's a provocative model that seems to be working and attractive to cities and other municipalities for which we try to engage.
If I may add to that, Cardiff, we started to look at bicycle and pedestrian injuries in our city, noting that the DOT gets their information from police, which is inadequate, just like assaults. And so we've wanted to do that and broaden that so that you.
Yeah, an exact example of that is, Jonathan, this is near his heart, which is pedestrian struck, right? We always look at crosswalks. Well, that's not where they're getting struck, right? That's just where it's getting reported. So, it's can we match the data of injury that we're seeing to the actual data that's in the field? And who is that we connect with to do that? I guess Jonathan has done a lot of work with our local our Georgia DOT, because they're full of engineers, and they have very few medically minded individuals within the departments of transportation at each state level. And so that might be another area, and they get tons of money. And so thinking about how to engage.
I guess I'll add to this conversation in that injury science has never been a massively funded field, with the exception of defense. And Purdo's got a big injection of funding, and that's actually another opportunity for continuing to support injury science that hasn't yet been discussed. So states have their opioid settlement money, and there's for example, in Georgia, there's a fund that you can apply to. The same structure exists in many other states, and so there's an example there of a potential source of funding. I also think we need to split sort of the conversation in terms of, from an injury center, the challenge that we as directors are facing is how do we support the administrative core of the center and the continued functions of the things that are really difficult to pay for on grants or on programs where the focus is on provision of services and studying those provision of services or testing and intervention, right? It's very hard to support someone whose job is administering your center on those funds. And so, our challenge is to try to find alternatives. CDC is the primary source of that support, at least for us. And so our challenge is trying to find something that picks that up when CDC goes away. Now, separating out the administrative core, going back to how do we support operations of the center and engagement in injury science, what Steve and David said is 100% correct. There are partnerships that we have. We've always had these partnerships. Trauma centers, our departments of public health, colleagues at other universities, foundations, DOTs, right? These are all partnerships that have existed on some level or another. One thing that's really important to note about those is that they are far more on the applied side than on the basic science side. And I think in order for injury centers and injury science to continue to survive, we're going to have to move a bit more to the applied side. It's going to be more program evaluation, more implementation science.
Could I add one thought just quickly on, I don't know if we've talked about this with Admin Corps. A new experience that I had in moving to University of Michigan was that when we prepared this grant for 5 years of funding, we went around to leadership of different units and actually almost got a 1-to-1 match. For every direct dollar that we brought in, we almost got $1 from internal funding with the promise of getting funded, which does help us support staff. And I don't know, I think we could also mentor other centers better to say this is a possibility and help them advocate. Please go ahead.
Thank you, Manny Murphy at Yale University. So speaking of tenuous funding, I direct one of the NIH D43 global injury research training programs. I don't want to discuss funding. I wanted to find out if any of you have experience working with partners globally to maybe translate some of the research that you've done at home to other settings, or to kind of collaborate with partners.
Yeah. When I was at Penn, we too had a D43 program funded by Fogarty at NIH, partnered with Botswana to grow injury science capacity. And in fact, that funding period ended shortly after the pandemic. But in my first year at Michigan, I leveraged internal funds from the African Studies Center to bring the MPI of that, Dr. Muketsi Molefi, to Michigan for 7 months to do sabbatical. And we are now helping leverage resources at Michigan to extend some of the projects that they have in road safety and in concussion. And we're trying to keep building momentum in that way, while Muketsi is still working with colleagues at Penn. So that is a way that we've tried to extend some of the momentum that we had from the inside of the ICRC in particular.
Fantastic. We are actually at time. So both Doug, Jonathan, and I are here for the SAM week. Please come find us if you have any questions, and we'll come find you if we think you can be useful in saving our injury science center enterprise. Really appreciate it. Thanks so much.
Yeah.